This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I'm Marion, physical therapist and your host, and today I interview Dr. Shirley Sahrmann to talk about the movement system. We discuss what the movement system impairment syndromes are, how to connect poor alignment and movement patterns with pain and injury, the movement system impairment examination and treatment, and much more. Dr. Sahrmann is a PT with over 60 years of experience. Yes, 60. She is a professor emerita of physical therapy at Washington University, a Catherine Worthingham Fellow of the APTA, and recipient of countless awards. She has authored 2 books describing the syndromes and methods of treatment. If this sounds interesting to you, I encourage you to subscribe to this channel, hit the notification bell for updates, give us a thumbs up, and share with other clinicians who could benefit from this information. Thank you for tuning in, and we hope you enjoy the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Systems for PT, the Do Anything Anytime EMR. Systems for PT develops systems for clinicians so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Sarah Health, and here is a special offer from our listeners. Visit sarahhealth.com/PTProTalk for a 90-day free trial. That's sarahealth.com/PTProTalk. Make RTM simple. Choose Sarah Health. That's sarahealth.com/PTProTalk. Hi Shirley, welcome to PT Pro Talk. How are you today?
I'm very good, Marion. Nice to meet you.
Very nice to meet you as well, and I'm super happy that you took time to come share all your knowledge with us today, so I'm super excited to ask you all the questions.
Right.
So let's get started just talking a little bit about yourself and your background.
Oh, that would take forever because I've got a big, long background. Now, I think what's a little bit germane to this, the idea of this podcast is I am old enough to have started with polio patients. And I know, look at her laughing. And the reason that was valuable is we understood what their problem was. They lost their motor neurons, muscles died, so they got contractures by the muscles that remained, and they were weak. And I was also, the vaccine came out when I was in physical therapy school. So I saw some of the patients, but also they went away. And because of the job we did with the polio patients, they started having us treat spinal cord injured, head injured, and they were saving the lives of those people, which they did not before. I think it's always interesting to know that a male 6 foot tall, if they were rear-ended in their car, became quadriplegic because there were no headrests or seat belts. So we had a lot of tall men that were totally paralyzed. And the reason why that's all germane is because with the as it is known, the upper motor neuron lesion, the central nervous system lesion, all the things we were supposed to do with the polio patient, we weren't supposed to do with the central nervous system patient, because you couldn't stretch them because you'd make the spasticity worse. You couldn't strengthen them because you'd make the spasticity worse. So after 9 years of not knowing what I was doing, taking care of neurological patients, I decided to go to graduate school so that it wasn't just a matter of me arguing with the doctors about what needed to be done, because I really didn't know. I did my best, but it was clear I didn't understand. So I spent 6 years getting a PhD in neurobiology, and so that I could solve the problems of the upper motor neuron syndrome. And that's why I talk about musculoskeletal problems. It didn't quite happen that way. And even though I spent another 19 years actually training monkeys and recording from their motor cortex. Yeah. And again, nobody invited me to Sweden for the Nobel Prize, but I learned a lot about the nervous system. So then, and I got associated with the faculty. I was always at Washington University, except my first year out of PT school. And then I was half-time in neurology and half-time with physical therapy, doing some teaching. We got a new director, and I started doing patient care. And he got me involved with the musculoskeletal patient. And actually, it was the application of what I learned from the neurological patient that I think contributed to developing these ideas and understanding of what should be called the movement system. And so then I was on faculty for more years than anybody likes to think about, and still am involved in some lectures and teaching continuing education courses. Yeah, so that's the background, and I have to say it wasn't just me. I was so lucky to be involved with people that were committed to understanding and doing things better. So they helped to work things out. They did a big bit in translating Sahrmannese into English and making it understandable rather than all kinds of vague terms. So I was totally assisted by a wonderful crew of people that we worked together for 30 and 40 years. Which is amazing. And no one resting on their laurels, but always pushing forward on the ignorance, on knowledge that we needed to gain. So that's a long background, but that's the way it is.
Nice journey. And I'm curious to ask you, how many years that you are a PT?
Over 60.
Oh, wow.
Yeah, I'm 86 years old.
That's amazing. So now I have to ask you, what is the secret to stay in the profession for so long? Because all we hear now about is burnout and all that stuff. How are you still up and going and fired up and passionate for the profession?
Well, in large measure, I was so fortunate because part of my early exposure was to a physician by the name of John Hollisey. And John, being a physical therapist, as you know, always involves a lot of physical activity. You weren't sitting at a desk. You were hauling big people around and doing things that were physical. And what Dr. Hollisey's work is to show, he was really showing by true translation research, the value of exercise for health and lifestyle. And when I was growing up, no one really knew that. You thought you just got the diabetes, you just got the hypertension, and you hoped the doctor could give you something for it. The food we ate, it was run over with fats and things. And if the green beans were too healthy, we had bacon grease to put on them. So, but with the influence of Dr. Hollisey, I came to appreciate the importance of exercise. So particularly when I went to graduate school, and now I was sitting a lot more than when I was working as a physical therapist. So I started jogging. I did better at watching my diet. And then I was so intrigued by trying to understand more about physical therapy. One of the other insights that I had that has played a big role was the whole patient, the patient referral thing, because when physicians would refer a patient as hemiplegic, that didn't help me. I was able to figure that out all by myself. And they were like paralyzed on one side. Quadriplegia, I was equally smart about that. But what it made me aware of is that the physician's diagnosis didn't help me understand how I was going to treat the patient. The patient's problem was related to their movement problem and the way their nervous system dysfunctioned. And that was not an insight by physicians. And so that started all these background ideas about we need to do something with classification. And that was totally pushed ahead and reinforced by the director of the physical therapy program that came in. His name was Stephen Rose, who died, unfortunately, at too early an age. But he really rattled my cage to make sure that I understood the importance of classification or diagnosis.
And I just imagine at that time how hard, like without any research to support you, no technology, no nothing. So it's way harder to look for information. Today we just Google it, search it, and we find.
You're quite right. If you wanted something, looking at research, you had to go to the library, go through journals, hope to find an article that was relevant. But Steve pushed us all into doing a lot more research. He wanted to have physical therapy faculty not be school teachers, but to be academics. And that was a big thing because a school teacher teaches whatever somebody else knows. and there was too much that needed to be generated in physical therapy because the work wasn't there, just as you're suggesting.
Yes, what a challenge.
Yeah, and burnout was never. It was just me and the profession. I'm not married, no children, so there was nothing else for me to do, but to work. And I loved what I was doing. I loved helping patients. I loved trying to figure out their problems, and I had the energy to do that. And then I had the colleagues, and they had husbands and they had children, but we never thought about burnout. What was different? We weren't pushed to make money. In fact, part of the growth of physical therapy in the United States is because, I'll use the real phrase, we were a cash cow. It's quite true. Physical therapy made a lot of money for hospitals and practices at the time. So there wasn't the same pressure because reimbursement was better, and we didn't get pushed along. And nowadays, I think people just feel pressured because there's so many options in life, so many things to do, and such a push to get it all done. So,
and I'm just curious to ask you, like, how do you think the profession changed, like in terms of day-to-day practice from your days to these days?
Well, in some ways, that's the big problem. It hasn't changed. I'll tell you what I mean. As I said before, one of the big changes is that now, instead of private practices or hospitals owning physical therapy services, large corporations own them. Mm-hmm. And the reimbursement is getting cut almost yearly for physical therapy services. So a profession that made a lot of money for people is no longer making a lot of money. It's just like for physicians and everybody else in medicine, that there's what you charge and what you're reimbursed. I mean, there's really a statement that if you collect 40% of what you bill, you're doing well. Yeah. And so there's great pressure on people to be more productive, just like a physician only has 8 minutes to spend with you. So they're using nurse practitioners and physician's assistants a lot more. They do what the doctor used to do. So it's the general trend. My other statement relates to what we haven't changed enough, and then we're still acting like a profession that only knows about treatments and doesn't know about the condition. And I'll let you ask another question before I carry on that way.
Yes. So talking about that, I know that you're talking about labels and like how diagnostic labels are important. So tell me more about that.
Okay. Well, so if I take it from the top, that as I mentioned before, my cage was really rattled by Steve Rose and the need to classify patients, because I thought musculoskeletal patients were really boring when I first started working in PT, because the doctor literally told you everything you were to do, ultrasound, diathermy, 20 minutes at 20 inches. It was too stupid. And that was just not interesting to me. And so that's why I concentrated on the neurological patient. But then things were changing. The doctors were more referring. And it also became clear they didn't know any more about what was going on with those patients than they did with the neurological patient. And so all of this, looking at what is physical therapy about, is to make people move better for functional purposes, for their limb purposes. And we assess movement, and we use movement to treat patients. So what made sense to me, and aided in many ways, was to define a system, the movement system. Now I will say in some ways I was very happy, because in 2013, unfortunately that's 10 years ago now, 11 years ago, the APTA, American Physical Therapy Association, adopted the movement system as our identity. And there's a big saying in many quarters of the profession that say, people know us for what we do and not for what we know. That if you do a survey, you'll find out patients want a diagnosis from a doctor before they go to a physical therapist, because the physical therapist is just going to deliver the treatment. And so we've specialized in treatment regimes without understanding the condition we're treating. Mm-hmm. So as you know, physical therapists in the United States get doctoral level training. I've tried to convince them that I could learn in 4 years what took them 7, but nobody's believing it. So, and in some ways it's wonderful, but there's been so many things added to the curriculum that my insight from Con Ed and other sources is that they've lost the core of physical therapy. The big knowledge about anatomy, kinesiology, biomechanics, neuroactivation is not there. It's gone off because there are other things that are more classy, more that people think are more interesting because it's new. Mm-hmm. So all of this to get to the fact that two things. Here are physical therapists being educated at the doctoral level, but nobody looks at them as doctors. So they spent all this money, all this time, and they're still looked at as therapists, doing what somebody else has figured out, which they haven't been figured out. So one that's relevant to all this discussion is, what do doctors stand out for? They stand out for expertise in a body system. They stand out for making a diagnosis or figuring out what diagnosis that you're working on, that you're heading towards. Well, we're not doing that. We're still emphasizing treatment. And I can tell you, just from the Con Ed that I've done, you just can't believe what people are doing for treatment when they don't even understand what the problem is. So, and one of the things that is problematic in the profession is called unwarranted variation in treatment. And why? Because you learn a treatment regime, that's your claim to fame, and then you use that, but you don't understand what you're using it for, because you don't understand the patient's condition, because we haven't built a knowledge base on movement. So the other big factor is that when physical therapy started, you had polio, and people got weak and their nervous system was affected. And so we kind of placed ourselves as looking for weakness to fix. And also problems were considered acute. So I just hurt my back. I just hurt my shoulder. And so the belief was, with this acute condition, that if you reduce the symptoms, the tissues would heal and you could get on your way. These are not acute conditions. They're chronic conditions. They start long before there are symptoms, and then they reach a threshold, and then they get symptoms. So in many ways, physicians treat symptoms and consequences, while physical therapy could really treat the cause. Mm-hmm. So the realization that these are chronic problems, that we could be on the side of prevention actually because there are signs before there are symptoms, and that we could really be helping people to understand the cause. And so one of my little sayings that I like to get the ideas across is that treating the movement to get rid of the symptoms rather than treating the symptoms to be able to move.
That's a very interesting, yes.
Well, I mean, but that's really what should be going on, because these are chronic conditions. And we could, and the big deal, we call it a kinesiopathologic model, is how movement induces pathology. So it's movement that's doing it. And I think in the physician world, it's accepted as eventual, that you're not going to change it. It's just going to happen. Well, just like with medical conditions now, and many physicians are advocating for this. Dr. APTA is advocating for medicine, not 2.0, but 3.0, prevention. And in many ways, medicine is much more preventive now than it ever has been. So getting on the front side, and medicine, what almost every condition is chronic. I mean, your diabetes starts long before your heart disease starts, et cetera. And so that's what's going on. And the other thing to mention about this movement system is there was pushback because it's not a basic physiological system like the nervous system or the musculoskeletal system, but it's a system of systems. And that's what the immune system is. That's what the metabolic system is. They use many parts of these basic systems for their function. And nothing's more important these days in medicine than the immune system. So to me, it's a package, is that physical therapists should be acting like doctors. They should be doctors who know all about the movement system, and people should understand that's our expertise. They should hopefully be seeing patients yearly. It shouldn't be you come in for 6 visits, never to be seen again. It's ridiculous. And that you should be giving people a movement-related diagnosis. And that's what we built our material on. It's what is the movement that most consistently elicits symptoms, and when changed, the symptoms decrease or are eliminated. And you got to look at the body as totally interactive. Only the orthopedic surgeon can only look at the shoulder without looking how it's sitting on the trunk. Same thing. You have to, if you're going to look at any body parts, you've got to look at the relationship of all of the body, because it's an interacting biomechanical system. And this is probably more than you want to hear, but
no, it's great. And I think I think very often we lose sight of the body as a whole, because you're very focused on like the shoulder and then what's the knee doing, and don't connect that link between all the movements, all the muscles. And that's why I was curious to ask you as well. So like, what are the syndromes, the movement system impairment syndromes? I know that you classify them, you have a bunch for each body part. So just tell us a little bit about that.
Okay. So again, they're named for the movement direction that causes symptoms. And with the lumbar spine, we've got a little bit of evidence. I can't say a whole lot of evidence, but that I believe in large measure, most of these conditions start with microinstability. So the joint, the accessory motion becomes excessive, and it's tied in with the body taking the path of least resistance for movement. So in most part, and I'll tell you, like with the shoulder and the hip, but with the back, even though I think the problem is with the accessory motion, I can't assess accessory motions of the lumbar spine. So they're named for the physiological motion. So it's lumbar flexion, lumbar extension, rotation, and then usually extension rotation or flexion rotation. And in some ways, the diagnostic categories, the movement diagnosis, follow some of the pathological developments, the pathoanatomic problems. As you know, when you get old, I don't know whether you know because you're so young, but people get old, and then they get, and I consider us all on the road to spinal stenosis. And when you get stenosis, or you have a spondylo of any sort or not, what can't you do? You can't extend. It's only flexion that's going to help you. So usually older people in chronic conditions have a diagnosis of extension or extension rotation, while the younger people that are more flexible, that tend to get in flexion of the lumbar spine, are the ones that most likely will get a flexion diagnosis. And rotation is almost a part of what everybody has a problem, because rotation involves shear during the movement. That's injurious to tissue. It's hard to control, and it's an intrinsic part of what we do every day. So, and we have an exam, a systematic exam we go through, and people are tested in a variety of positions. And one of the big things, just to make this point about interactions, is I would say conservatively, 80% of the people that have back pain, it's because their hip isn't working optimally. And I'm not saying OA of the hip, I'm just saying that muscle differences, for example, if the tensor fasciae lata iliotibial band becomes stiff, and that's another part of what's important here, is stiff versus short, is then very often, because the tensor needs to, flexes the hip, immediately rotates it. Instead of the hip really extending and medially rotating. The lumbar spine begins to rotate, so you get pelvic rotation because those muscles aren't letting go. And once the spine starts to rotate more easily than the hip, it exaggerates the problem and it goes on from there. So we have the diagnosis, but they're based on a systematic exam. We look at people standing, do tests in standing, supine, prone, quadruped, and we also look, and the other important part about this, and this has been shown by Linda Van Dillen's research, is you have to change the way people do their everyday activities, because it's the way they do their everyday activities that causes the problem. So much of the intervention is understanding the movement problem and helping them understand how to correct that problem. More effective if you use motor learning principles for instruction. And I mean everything from how you roll in bed, how you go to sit to stand, how you walk up and down stairs, how you work in the kitchen, etc. So, and I think the other thing, and I had examples when teaching the course this weekend, that's so useful about this way of looking at patients, is that you're showing them what movements hurt, and you're showing them how to change that movement so they don't have symptoms, or their symptoms are less. And I'm a big believer, if you're not having symptoms, you're healing. So, and it puts the patient in charge. They're not so frightened about what's happening to them because they feel much more in control. And if you've ever had a bad pain, that's what you want to know. Why do I have it, and what am I going to do about it? So, I mean, in the shoulder, I'll just, let me go to I'll go to the hip. In the hip, actually, I'm kind of proud of myself because we talked about hip syndromes before anybody was really talking at all about CAM lesions or any of the things that they've now identified in the hip. And so we have femoral anterior glide, which is an accessory movement. We have posterior glide, which doesn't happen as often. Femoral medial rotation syndrome. We have some that are more physiological motions, and that's sort of the idea of these syndromes. Yeah, and it's sort of a multi-directional movement as well.
Okay, so like when we start talking about that, you said that most of the problems start with microinstability, right? And yeah. What does it cause that?
Why does it cause that?
Mm-hmm.
Because it begins to injure tissues. If you must know that if the head of the humerus stayed centered in the glenoid, there wouldn't be any problem.
Mm-hmm.
But it doesn't, because of the way the scapula is moving and because of the way the humerus is moving. So it starts to move around, and then you get injury to tissues. So not moving optimally as it should is what, and it starts to move too much. That's what injures the tissues within the joint. In some ways, I find it so amazing that people can identify one tissue. If your back is bad, every tissue back there is bad. It's not like the facet joint is bad. If your disc gets smaller, and they do by the time you're 20 or so, in many cases, now you've got greater overlap of the facet joints. Now that place begins to move too readily. So it keeps increasing the range of motion. It keeps increasing the fault in which it's moving, and it becomes damaged. That's what leads to the movement.
So it could be caused by the way we move, the way we are positioned, the way we sit, the way we were born.
Well, I mean, that's an important point you're bringing up. Yes, not everybody is built perfectly, and there are a lot of structural variations. But how well so you know what femoral anteversion is? So the head of the femur is rotated too anteriorly. And it's more prominent in women than it is in men. If you decide to become a ballet dancer and you have femoral anteversion, if you try to get the turnout you should get, you're going to be injuring your hip. There's no two ways about it, because you can't get that much turnout. If you're a man who has femoral retroversion, and you decide to do water polo, which involves a lot of medial rotation and adduction, you're going to get a hip problem because you're going into places that you really shouldn't go. This is where I see physical therapists should be doing a lot of preventive things in helping somebody understand what is the best sport for them, because after they move along in it, that's their identity, that's their friends. And I've seen that numerous times with patients. So yes, you've got to take into account structural variations, the individuality of people, and the way they do, what activities do they choose? Do they do ones that help them, ones that hurt them? Are they very flexible? Are they tall? Are they short? Do they have wide hips? Do they have a long trunk? All of those are important factors in assessing how they're moving and what the effective activity does on them. I've always been intrigued that people that play sports have so many injuries. They don't all play football where somebody's hitting them. They're running down a field or running down a court. Here's an injury. Why? Because, and here's a really interesting thing. The body works to be efficient, but it's not good for your musculoskeletal health. Meaning that if you get some muscles developed, the body keeps using those muscles rather than other muscles. Let me give you an example. If you have abdominals that are not very good, particularly the external obliques that posteriorly tilt the pelvis, your hamstrings are going to become the major mode of tilting your pelvis. So the more you use your hamstrings, the less you're going to use your abdominals, and the shorter and stiffer the hamstrings are going to get. And your body will keep doing that for all activities because those are the ones that work best. I can go the other way around for another explanation is if you build up your abdominals so much that the rectus abdominalis pulls your thoracic spine into a kyphosis, and then you sway back so that you're not dealing with bent over all the time. You sway back, and when you sway back, your abdominals become the anti-gravity muscle. So that means if you even pick up anything, you'll sway back to use those. And what muscles don't you use? The back extensors. So you're at risk if you bend over to really pick up something unless you can pick it up and immediately sway back. Now, the more these are the anti-gravity muscles, the less the back extensors work and the more the abdominals work, and you substitute all your movements to be able to use those to a maximum.
So I guess just about everybody needs an assessment.
Yeah. I mean, well, that's true. I mean, just like you go to your physician for a yearly exam, why not?
Yes, because everybody's going to develop their own compensations. Their bodies are going to find a way to move and do whatever they need to do, and other body parts are going to suffer. Someone will suffer.
Exactly.
Right?
Yeah, exactly.
And as you were talking about the hip and the back, I start thinking about like how we know that today a lot of hip pain comes from the back. And now you are saying that a lot of back pain is caused by the hip. So that's kind of like an interesting relationship there, because you're always thinking the hip symptoms, a lot of them, like on this exposed study now, Talking Mackenzie, that they show that a lot of hip pain, 70-something%, was proven to come from the back, and how the hips are also, like in that relationship, giving the back pain. So that's kind of interesting.
Well, I think I would say, based on my clinical experience, that you've got a lot more incidence of the hip affecting the back than you do the back referring pain to the hip. And I think, in fact, one of the things that I got started early on was looking at the hip itself, because when the hip's not moving optimally, you get pain in the hip. And I think now they know a lot more about structural variations, and then it still needs to be shown how well we can intervene, because, I mean, here's a simple thing itself. And part of why I think some terminology needs to be changed. One of the things is people talk about normal range of motion at the hip. Okay. I don't believe there is such a thing. there's an average, and it's just like height. The average height of women is 5'4", but we don't cut off the legs of those that are 5'6" and put them on people that are 5'2". There's an average, and this is the average. So people that have anteversion, femoral anteversion or femoral retroversion aren't going to meet the standard of what's normal range of motion of the hip. And the same things with hip flexion. When people, they're seeing now there's a much greater incidence of CAM, or what they call femoral acetabular impingement, FAI. Therapists have been trying to flex the hip on people that don't have the ability to flex the hip because the normal range of motion is about 120 degrees. Well, they're just injuring the hip, trying to meet the normal without taking into account there are these structural variations. So there's a lot of things that go on in the hip that can be identified as movement faults. And as long as people aren't thinking everybody's got to get to the same range. I've been astounded that few people, when you examine a back patient, you've got to know whether they have femoral anteversion or femoral retroversion. Because if that hip doesn't move the way it should, you're going to compensate in your lumbar spine.
Yes. And so, like in your exam, what are the things, just a few examples that you do, and how do you make sure you're getting to the cause? Because it can get challenging to find out exactly who is dominating that pattern.
Well, I mean, in some ways, it's rather straightforward because, as I said, we have this systematic exam, and we're looking. And we actually did reliability on this, and it was published this was for the lumbar spine, but I think we could do the same thing for the hip and shoulder. That one, you look to see how the patient performs the motion naturally. We call that the primary test. And let's say we'll make the examples. Well, you want to know about the hip, so I'll carry on with the hip. So if the patient has pain when you flex their hip or you do a straight leg raise, then what you often see is the femur, they have an extra amount of flexion. It'll flex and medially rotate. And it should be that with the motion of the hip joint, you could drive an axle through it for flexion and extension, and the axle shouldn't move. And it does in this case. And so you change that movement and the symptoms decrease or go away. And then you do it not just in one position, you do it in every position. So you're seeing the constancy of the problem as well as the change making a difference in eliciting symptoms. Another example that might be easier for people to follow, and this is just too straightforward. If you have somebody that bends over and their hips don't flex well and their lumbar spine has excessive motion. Now, and what's excessive? Well, 20 degrees of lumbar motion you can get, but sometimes you don't even need. I mean, that's what the standard is. But you don't know in the lumbar spine whether you're getting 15 at one joint that should only give you 5 or 6. That's the tricky part. But they bend over, and this has again been published, and their back flexes, and then you have them change it so they bend over with hip flexion and no lumbar flexion, and they don't get symptoms. So you're right away teaching the patient, now you bend over this way and you don't get your symptoms. If you sit and you sit in lumbar flexion, you got symptoms. If you sit up straight, you don't have symptoms. So, and taking into account like these structural variations, if you have somebody that's very tall, well, the example we were talking about before, if you have FAI and you're sitting, your hip is not going to flex more than 90 degrees, maybe 100 if you're lucky. If you're tall and you're sitting in a chair that has your knees higher than your hips, you're going to sit in lumbar flexion. If your hip doesn't bend well, to get out of the chair, you're going to bend your back. So putting together structural variations with the movements that hurt do not look optimal from a kinesiological standpoint, and there's structural variations. You change that, symptoms decrease, that's 1 + 1 = 2.
So when you are assessing the movements, you are looking for that position that releases the symptoms?
not just the position, but the movement.
The movement.
Alignment is one factor, and yes,
Mm-hmm.
changing the alignment so you don't have symptoms is good,
Mm-hmm.
but also looking at the movement itself and then changing it.
Mm-hmm. And then when you find the movement or position that reduce the symptoms, then you use that on your treatment or to
Sure.
advise them on like their day-to-day, you don't avoid doing this motion, do this way.
Well, it's more than advise them. I mean, yes, I'll tell them you have a lumbar flexion problem. That means when your back bends, you're getting your symptoms. And as you saw a patient, when you bend over and you're only using your hips and you're not bending your back, you don't get symptoms. And now let's look at how you sit. Let me see how you walk. Tell me what your activities are. And then we'll go through the activities that are important. What is your car like? Do you sit slumped in your car? Do you have to lift your leg up too high if you have femoral anteversion? What happens when you get out of bed? So you go through all of their activities to help them learn. When you put on your shoes, do you bend over in your back? Do you have to pick them up, bring them up to you and not bend your back? What are all the little things? And in some ways you can start it off by saying, well, what is it that gives you symptoms in your daily life? And that is another clue as to what's going on.
So like when you assess, let's see if I understood correctly. So when you are assessing, you are looking on their movement. So first you ask them to just do the movement as they would do, so you can kind of identify the patterns. Then you try to reduce their symptoms.
By changing the movement.
By changing the movement. And then what would be the next step?
Well, I mean, so you're going through this in a number of positions, and you try to identify what are the contributing factors.
Mm-hmm.
If it's a lumbar flexion problem, too much abdominals will contribute to that. Not enough back extensors will contribute to that.
Mm-hmm.
So that there's exercises that you give them to try to correct that. But also, as I mentioned, we'll go over their daily activities. Mm-hmm. And so if they hurt, what do they need to do differently? Why did that hurt when you did that? What do you need to do differently? So you're not just telling them that. You're taking them through the correction of the motions. It's very hard. It's very hard for people to change what they do every day. And I also like to make this point always. And I had a good example this past weekend. People, you do not know what you're doing wrong. You only know what's familiar, not what's right. We don't have an internal sensing machine that says, oh, you're deviating from the industry standard. You just deviate from the industry standard, and somebody's got to come along and tell you you're deviating, and it's what's hurting you, and this is how you have to change it. Mm-hmm. So, yeah.
Because if you don't change their day-to-day, it's going to be really hard to correct long-term, because you could potentially stretch or strengthening the muscle or something that's causing the imbalance. But if they're repeating over and over on that same way, it's not going to have good sustaining results long-term, right?
Right. You're going to keep re-injuring yourself. You're reminding me, you've got the whole idea. And one of the things that's important is when people like to exercise or do an activity, you also have to find out what exercises are they doing that's playing into the problem and get them modified, because they're going to undo everything you've tried to do during your session.
Mm-hmm. So like the treatment would include those assessments of their day-to-day activities, and then correct if you have a muscle that's too tight or a muscle that's too weak, then you would correct those imbalances as well with exercises?
Well, you would modify what they're doing. I had an example this weekend. This fellow is lifting 45 pounds. His shoulder is already dropped, and he's doing an exercise that pulls his shoulder down. Well, that is not a good idea. So, you're trying to show them. And I'm going to make one more point since you brought it up. As I mentioned early, is that with polio patients and that, we knew why people were weak. And I always like to ask the question, all of the muscles in a musculoskeletal patient are normally innervated. Why do they get weak? And the reason why they get weak is for the reason we talked about before. You're using other muscles more than those muscles. Just strengthening them isn't going to change anything. You've got to it's the pattern of activation that's doing it. So you have to change the pattern of activation, not just strengthen a muscle.
Mm-hmm. And that goes into the training, their daily activities, the way that they move. So that would that be the most important piece of the treatment?
It's definitely the most important part. Mm-hmm. I think having what I think are necessary exercises can facilitate the change as well. For example, if you have a thoracic kyphosis, that, believe it or not, that one of the best ways to decrease your thoracic kyphosis is in the quadruped position. So on hands and knees, mm-hmm. and you're letting your thoracic spine go down. And also, if it's because your abdominals are overdeveloped, arms up overhead, taking a deep breath. So you elongate those abdominals. And you do side bends, but you move in the thoracic spine, not in the lumbar spine. So specific exercises that address some of the muscle adaptations is also a very useful thing. Mm-hmm. I think the big point I want to make is you can't say, I'm just going to exercise the abdominals and think that that's going to work, because you've got to put the whole thing together, and they have to use the abdominals during their daily activities as well, not just when they lay down to do 10 repetitions or even 20.
Mm-hmm. And I think that's a big piece that we miss on like the functional aspect of things, because we see them moving in isolated ways and not connecting everything.
And another thing's related, Mariana, is what we talked about before. This takes time. So if you have the pushback that you have a limited amount of time with a patient, you're not going to have time to go through all of this. Mm-hmm. And my big belief is I'd rather have an hour with a patient than 20 minutes 3 times a week. In fact, I never saw people at the most once a week, more than once a week, because they're to go home and do their program. I don't want to be the one that's doing it with them. They need to do it on their own. They created the problem, I tell them, and they've got to fix the problem. So I think you've got to have a practice situation in which you are allowed adequate time to address this. My big belief is that the future ought to involve more cash pay things. People pay trainers, they pay masseuse, and in some ways they're paying them more than they are physical therapists. And that's another thing that upsets me, is that if somebody wanted an exercise program, they would never consult a physical therapist. They'd go to a personal trainer, a yoga class, or Pilates class. And that's doing those things without knowing whether it's good for them or the way they're doing them is right. I'm all for them doing those things, but somebody should figure out first how they're doing it and whether it's appropriate for their activities.
And then you send them home, and then they are trained and empowered to understand that they have to do that specific movement that way, so they don't have the pain. So the pain is going to be their guide.
You got it.
Okay, awesome. And how did you identify all these patterns? So that's the question. It's just observation.
I had nothing else to do for 60 years. In some ways, I've always wanted, I was kind of raised this way, to try to understand what's going on. How do things work? I mean, from the age of 2 or 3 on, my father was always, how does that work? What is it doing? And I was always intrigued by how people move. We make great judgments about that. And then you study normal gait, but I've never seen anybody use it. And how can you recognize somebody at distance by how they're moving before you can see their face? Because it's very individual. I also was intrigued, believe it or not, because some of my patients that could be marathonists had no calluses on their feet. And other people who just walked around had so many calluses, I don't know how they got their shoes on. Well, why was that if we're all using normal gait? What are they doing differently?
Yeah.
So I just kept looking it out, putting people in quadruped combining my knowledge from the polio patient with the neurological patient. And it all kind of start fitting pictures. And then, as I told you, I had these colleagues that helped me to work things out. They happily had obsessive compulsive disorder, so they were very particular, while I had attention deficit disorder. And the combination worked out well. We just kept working at it, figuring out more, meeting regularly, and putting the pieces together.
Very cool. And you said that the body takes the path of the least resistance for the movement, right?
That's correct.
So like in your experience and all these years observing, so what are the things that play a role in like deciding where the body's going to go?
Well, as we talked about, your sport, your activity, the way you're built. Again, I'll give you a big example. Many women have a really broad pelvis.
Mm-hmm.
And if they have a broad pelvis, one of the things they can have is femoral coxavera. So the angle of the femur is more 90 degrees than 120
mm-hmm.
degrees.
Mm-hmm.
If you have a wide pelvis and you sleep on your side, you're putting your back into a side bend. Okay. If you go to roll over, your upper body gets there a half an hour before your lower body. That kind of pelvis also contributes to the TFL getting stiff. It doesn't get stretched. So when you walk, you get excessive lumbopelvic rotation. Now you've set up in all those ways for the lumbar spine to do more rotation than it should. So everything you do, it's going to be easier for it to move there than in the other places where they move. So what is your structure? What is your activity? And how does that play out in your movement? So that start off with the microinstability, it becomes macro, and then you have a physiological motion problem, and you've got a pain problem.
And you usually see people when they are on that stage that they have already developed the pain, and ideally would be catching all of these before it becomes pain. Right?
Exactly. And I'm going to bring up one thing, another thing, since you're asking about the path of least resistance. There are 3 things that we've identified so far that contribute to that path. We call them contributing factors. And one of them, and I'm so disappointed that more people don't think about this, is the stiffness of musculature. And it's the relative stiffness. Now, everybody knows if they try to do a straight leg raise, they feel the resistance of the hamstrings. But guess what? Every muscle has that stiffness. And I happen to have a couple springs here, so I'll show you what I mean. If you have, let's say you've got hip flexors like this spring, and you can see it's big and it's stiff, and you have hip abdominals like this spring. This spring, when it gets stretched, is going to move the other spring.
Yeah.
It's not going to stretch itself.
Mm-hmm.
It's not short. It's just stiffer than. Stretching this is never going to change it. Mm-hmm. Stiffening this will, so that you get a situation that looks more like this.
Mm-hmm.
So one is the relative stiffness of musculature. Another factor is what we call relative flexibility, and that pertains to the joint itself. Like we talked about, if your glenohumeral joint becomes hypermobile, and the head of the humerus spins around rather than staying centered like it should, that's changing in the joint, so there's more relative flexibility in that joint. And we have a syndrome called anterior glide. So the head of the humerus anteriorly glides where it shouldn't glide like that. It's excessive, and you can see it with numerous activities as well as position. So what is the joint itself doing? What's happened to it? And then this factor that I sort of alluded to before, it's called the pattern of activation that's connected with motor learning. So you put all those together, and they're highly interactive, all of them contributing to this path of least resistance.
Very interesting. I love the example with the springs because it's very clear, and I think I would get stuck on stretching the hamstring and not thinking about the other way around. So I thought it was very interesting.
This reminds me, I think it's so important for people, particularly young practitioners, to make sure that everything makes sense. So let me give you an example of why I got onto this spring thing, is that I was taught that if somebody was prone and they flexed their knee and they went into an anterior pelvic tilt, it was because their rectus femoris was short. Okay. So being the person I am, I thought, well, that's going to be interesting. I'll prevent the anterior pelvic tilt, and then the knee flexion will stop. Well, guess what? I prevented the anterior tilt, and the knee flexion went on. It's like, you aren't supposed to do that. Why did that happen? And so, as swift as I am, 15 years later, I finally got it worked out that it's about the relatives this is what's so interesting too. You look at somebody standing and you say, why do they stand the way they stand? And the reason why they stand the way they stand is to minimize energy expenditure. Okay. That means you're going to use as much passive tension as possible. So this thing of what is the relative stiffness is a big factor in determining your standing alignment, your sitting alignment, if you're not using a supported chair, et cetera. And that all reflects the passive tension. And the bigger the muscle, the greater the tension. You feel like you've been through a Con Ed course?
Yes, pretty much. I'm trying to process all this information. I was like, oh my gosh, is the curiosity and like being analytical and observing and asking why and
exactly.
to try to understand.
Yeah,
that's impressive. Very impressive.
Well, as I said, I had nothing else to do, so it was easy to do.
Yes, that's very interesting. And then, so you developed this approach for first of all, the springs she was showing on the video. For the ones that wanted to see what she was showing with the springs, go to our YouTube and look at the video. I'm going to make a little minor point. Okay. I don't like to call it an approach. I like to call it, approaches mean get thrown into the bundle with all the other. Are you using NDT? Are you using MDT? Are you using McKenzie? Or, it's not the treatment method. I like to believe this is understanding and application. I'm understanding how the movement system works, and I'm applying intervention for the problems of that system. Mm-hmm. It may sound picky, but even our accreditation requirements, the only thing we really need to learn are treatment techniques, not a body of knowledge. I mean, you say they list courses, but they don't say what you're supposed to get out of those courses. Mm-hmm. That's so therapist-like. I'll even tell you, I believe we need to change our titles. We should not be therapists. If what
we're
should
doctors,
we be?
I'm not committed to a specific term, but it's something like movementologist. Speech has done this. They don't have speech therapists anymore. They're speech and language pathologists. Mm-hmm. I think using pathologist would not be helpful because it would kind of interfere with being on the prevention side of things. It's like you've got to have a problem rather than, that's why I'd rather have the ologist where it's the study of movement, like neurologist, cardiologist, ophthalmologist. Mm-hmm. It just speaks to the expertise of the system that you're an expert in.
Yes. So you develop a system?
Thank you very much.
So people that they are interested in, like they like what we are talking about, if they want to get more information, they can where they can go to look for the movement system.
We've actually tried to set up a continuing education process. And so there's Learn Movement System. And happily, one of our colleagues is sort of heading this effort to help people have the opportunity to learn about this, learn about the movement system and how to understand it and develop approaches that work with that system rather than here's another little thing. And so it's called Learn Movement System. And if you go on, if they Google it, they'll be able to find and contact her. And we have a number of videos and all that available for people to see and learn from. I think continuing ed these days, just like you doing a webinar, or a podcast, is much more Zoom. People are not going out physically to do courses nearly like they did before. And it costs less, time is less, etc. So I think in some ways that makes sense. And, I think one of the other things that's interesting about doing things on Zoom is that everybody's seeing exactly the same thing. If you're in a big classroom, there's different views. They think you're doing something different with your hands or seeing something different. But when you're on Zoom, everybody's seeing the same thing, and they're not distracted by the 10 people in front of them, et cetera. And the other thing that's advantageous is they can ask questions without interrupting the program unless it's necessary. So I have somebody monitoring the chat, and they'll answer the question for me unless they bring it up, and it's important to the whole understanding. So there are advantages. There are disadvantages, but there are advantages.
Yeah. So, and you're still teaching courses on movement system, like you told me that you were last weekend. That's amazing.
Yeah.
Never gonna retire.
Oh, why should I? As long as I get the opportunity to keep, I'm so passionate about this profession, and I am so worried because I know what we could do. I mean, we could radically cut the cost of healthcare. It's not like you're not going to get these problems. Just like you're not going to get heart disease, you're going to get it. You got to die from something, but you'd rather get it at 80 than at 50, or even 20s or 30s. I mean, look at the reoccurrence of back pain, hip pain, neck pain. Or people have to modify their life because they haven't had a successful intervention, or they go through incredible kinds of treatment just because they're scared and nobody's helped them figure out the cause.
Yeah. And do you use, I'm curious to ask about integration, like when you're treating, you use the movement system, and then do you integrate it with other approaches, systems, methodologies? Like what do you see? Like do you see the need to use other things inside your treatment?
No. Most of the patients I saw had already been to physical therapists. And doctors would say, she's not a typical physical therapist. And so that's how they got them to come. And and they said, well, those other therapists did this nice heat and all that. I said, well, you're cooked enough. And it clearly didn't help, or you wouldn't be here now, which I could get by with. And no, I mean, if it's an acute injury, do what you need to do, or it's post-surgical. I'm not talking about that. I'm talking about the standard chronic musculoskeletal problem, and not with clearly traumatized tissues. And the whole thing is to change the movement. I'm going to go back to my saying, change the movement to get rid of the symptoms. Don't try to get rid of the symptoms to be able to move. That's not taking care of cause at all.
And do you see, because I was interviewing Darren and he was mentioning how he integrates all the systems. And that's why I was kind of asking you that question, because I know he uses, like the Maitland, McKenzie. And he told me on the podcast, he told a story of how you were together and then he was treating someone and then you said something that he wasn't thinking about and he was like, what does she mean? And then he started telling all the story. So that's why I was curious to ask you if you would use
this was the time where they tried to compare 3 approaches, McKenzie, Maitland, and what we were doing. And we all had different patients. And then he was going through his patient and he was sort of stymied. And he looked at me and he said, I bet you know what's wrong. And I said, I do. And so he was, I really handed to Darren because he has enough right ego that he didn't mind asking me and having me coming up and go through it with the patient. And I really credit him on having such an open mind. I am not one that can integrate all of those different things because I have to understand what's going on, and I don't understand what those things are about.
Yeah.
Let me make one other statement, so people might really dislike me after this. But in some ways, doing treatments that make patients passive recipients, so they become dependent on that, is not helpful to the patient. I think that's why we've got so much pain in the brain. It's when you teach them this is hurts and this is what doesn't hurt. And to think somebody has to push on their back or on their joints to make, and in some ways, and I think our evidence is pretty solid, it's what's moving, not what isn't moving. Now, I can say if a point isn't moving, well, you're going to move more at another point.
Mm-hmm.
But you always have to ask, why did it get that way? And what are you going to do about it not getting that way again? And the point that moves too readily has got to, if you think you're trying to move something that doesn't move well, it's got to move as easily as the part that's moving. And that's not going to be easy. So it isn't just a matter, if you need 2 hands and 2 feet to change something, it's not going to change where you're moving. That's why the spring idea is so important. You've got to stiffen what moves too readily. And it's not going to happen by stretching something else.
Mm-hmm. Yeah, I love the concept.
Good.
Good. Yeah, because we see that some things, respond to different patterns, and some things we can change, and that makes sense. So like when you're treating, and you said that you would prefer to see them like more, every month or every other month, or not like not 3 times a week because they have to go home and practice that. So like for how would look like a treatment time-wise? Like how would that look like? Would you see them, how often, and like to see results? Like, they have to be doing their homework for, I don't know, X amount of time.
Typically what would happen is that it would take me about an hour. I wanted an hour for a patient. Now, I could charge legitimately for an examination, therapeutic exercise, and therapeutic activities, because we did all of that. And I would be teaching them. So I go through the exam in many ways. When they fail the test, it becomes their exercise. But I want a big picture before I make any decisions about that. And I also want to size up the patient. Is this somebody that's really going to do exercises, or this is somebody clearly not going to do exercises? So then I'll put more effort into changing the critical things in their everyday activities rather than trying to teach them an exercise program. I'll say these are pretty necessary. They're the ones you need to do. I'm not going to worry about all the others. And then we'd go over and print out the exercises, sit down and go over them with them. If they didn't understand, we'd review it over again. I wanted them to go away for a week at least. And I would tell them, if something hurts, don't do it until you come back, because nothing should hurt. It all should help. And then they come in the next week. Now, if they look at me blankly, like I didn't do anything, well, they get one more try and then it's over with. No, well, there is no point. There's a lot of people that want to.
Yeah.
A lot of people that need help, and I wasn't going to waste my time on somebody that didn't do it. But if they came back in the second week and they're better, and they were usually better before they left the clinic, then I'd spread it out to 2 weeks, and then once a month. If I didn't have the option as such, if some people would do it themselves, they'd set it up themselves. But if necessary, once a month, once every 3 or 4 months, whatever the extent of their condition, how severe was it, or not, how well are they learning, how hard are they trying. I would take a lot of what the personality was into count. So, and then they also, I want to minimize how much I have to come here. I've got too much to do, and it takes too much time, et cetera. And that was the other advantage of once a week. Coming in for 20 minutes 3 times a week, ridiculous. You have to take all this time out.
Mm-hmm.
And just to have somebody do something to you rather than you learning that patient learning what to do is only reinforcing their problem, not helping them get rid of their problem. And, I think in the ideal world, I'd also have a facility that has a gym and personal trainers that I would have trained. I'd be examining the patient first, making sure the patient understands and the trainer understands what they're to do and how they're to do it, what their specific things were. And if they want to come in and exercise and have supervision, go for it. That's on their own. They've got to make that decision. And then I also would not have somebody undoing everything we were trying to do.
Mm-hmm.
So that was the typical mode of the way I would practice.
And then when they were good enough, being able to empower enough to learn how to do their movements without pain, then would be when you would consider discharge.
Yeah. As I say, if I had my druthers about today and all the rest of it, it didn't quite work out before I retired, I would say, I think you ought to come back in 6 months, or you're going to take up a new sport. You're going to decide to run now or play tennis. All right, let's look at what's going on in the way you do it. That would be the other thing that would be a criteria for me. I think everybody should come in once a year anyway to be checked out.
Do like a screening, see how your movement's looking like.
Right. And if you get a pain problem, then make an appointment to come in,
mm-hmm.
just like you would with a real doctor. The idea of you get 6 visits and then you beg for the rest is ridiculous. And then you want to front load those 6 visits in 2 weeks? Ridiculous.
Yeah.
It took you years to get this way. It is not going to go away in 2 weeks.
Yes, very true. Shirley, anything else to add before I ask you my final questions?
No, I think I've made all the points I wanted to make.
Good. So if people want to learn more about this topic, any resources that you recommend?
Well, as I mentioned to you, if they're interested in continuing education material, if they Google or look for Learn Movement System,
mm-hmm.
they'll have a lot of resources.
Mm-hmm.
There are 2 books, one written a half a century ago, not quite, 20 years ago, unfortunately, but we are working on a new edition. Unfortunately, I've been working on it for more than I should have, but we hope to have it somewhere out in the next year or so. But it's called Diagnosis and Treatment of Impairments and Movement Impairment Syndromes. And that takes care of the hip, the shoulder, and the back. There is nothing wrong with that book, but we have much more evidence. We didn't have very much evidence. It was just based on anatomy and kinesiology. We have more insights that nobody knew about those hip things when I wrote the book, and a few physicians. And then the shoulder diagnosis we've modified some. And then the second book takes care of the cervical spine, thoracic spine, elbow, knee, and foot. Yeah.
So people can have a good basis if they go read those books.
Yeah. So if they're interested in trying to read about it, also if they look at research by Linda Van Dillen, capital VAN, capital DILLEN, about the lumbar spine, that they will have a lot of insights about really evidence for the things we're doing.
And there was an article that you sent me that was really good too, and it's actually in the Brazilian Journal of Physical Therapy.
Yes.
So yeah.
Yes, actually that gets cited a lot because it was kind of a comprehensive overview.
Yes, a good overview. Yeah.
Yeah.
Easy to understand.
Right.
And then for the clinicians that are starting their careers, any advice for them? With all your 60 years of profession and wisdom?
I can't overemphasize enough is like, I wouldn't take the word of anybody for anything. It's like, does it really make sense? Not to just pick on things, but this whole cranial sacral thing, like you can move the skull around. I mean, it's too ridiculous to even think about. Does it really make sense? Would you talk with a straight face to a doctor about it? I mean, that's a really big thing. So to me, needless to say, I think it's advantageous to think about this movement system and all the things involved in movement to appreciate. That's what we're trying to get patients to do, to be able to move, whether it's a neurological injury, cardiopulmonary problem, or musculoskeletal. It's all, and there's nothing is as effective in treatment as exercise. I mean, whether it's dementia or cancer, exercise can play a role in those conditions. So we should be looked at as the super experts in that. And then I think understanding the patient's problem, not learning techniques and building all of your reputation on, I know how to do X. That's not what's important. What's important is understanding what you're trying to do and how movement affects that condition. And keep trying to figure it out. I'll just make one more statement. There's no way we think that these diagnoses are the end of it any more than a diagnostic system is the end of it for medicine. I have a friend with breast cancer, and when I learned about all the things they now know about breast cancer, it's unbelievable. And yet I also had heard a statement that 60% of breast cancers that are diagnosed don't need to be treated, but they don't know what they are. So they're going to keep learning. We're just saying, here's a start, and we want to build on it. And if you young, smart people come along and help us to figure out how to do it better or what should be modified, that's exactly what we want. These are not the end-all, be-all. This is a start.
Very nice. Profound. Shirley, if people want to find you or contact you, is there a way that they can do that?
Well, I am on email. I don't do any social media. In my email is my last name with an S at wustl.edu. I'll just have to tell you, because it's when you talk about people contacting you, when my book first came out, and I again was slow on getting it out because the first one would have been carved on stone walls or printed by hand. But when it first came out, happily there was Amazon.com. And that ended up really helping sales because otherwise you'd have to go to a medical bookstore. But the reason why I bring it up is that I was contacted by people that were not professionals, but had gotten the book and had figured out their own problems.
Oh.
And were checking with me about it. And I was so impressed by them that they did it and they were able to use the book to do it.
How exciting.
Yeah, and I also have to tell you that that I've been so impressed with the Brazilian people. I'll tell you an incident. A number of years ago, a group of them wanted to come up, I don't know, 3 or 4, I guess, came up to St. Louis to take the continuing education course. And we were running a level 1 and a level 2 at the same time. And they came early to observe. And I was so impressed with what they knew that we took them out of level 1 and put them in level 2 because they had been so good. And I actually have been in Brazil once, and then I had a mess up going again. And I was so impressed with the knowledge and the commitment of the Brazilian physiotherapist.
I'm glad to hear that. That's good.
Yeah, well, I'm glad to share that too with you.
Awesome.
They've actually, Paula Ludwig has done a bit of research, a fair amount of research with the Brazilians. And Paula, to me, is the ultimate of the shoulder researcher. Yeah, if you want another interview, get her.
Let's. I'm writing down. Very good. And I just wanted to give you kudos. I saw your exercise routine on YouTube.
Oh, did you see it on Tim Ferriss?
That your interview with Tim Ferriss, right? And then you record the exercise routine. So if people are wondering what is the secret, I guess, to get to 86 like you are, you're just talking about movement. Here it goes, leading by example.
I also was a colleague of, you probably don't know the name Florence Kendall, but she was the original muscle testing posture lady. And I can't emphasize enough trying to maintain as good an alignment as you possibly can. Truly, there are structural variations, that's for sure. But not letting yourself develop a kyphosis, correcting an anterior pelvic tilt, all of those things to me help, so that at 86 I can get up and down off the floor without difficulty. And my sister, who's 15 years younger than I can't. Yeah, I decided to do the video myself because I thought, rather than getting some beautifully structured younger person, that I wanted to go ahead and show that an older person could do this.
Yeah, that was
try to make the points.
Very impressive. Yeah, that was nice, because I hear the podcast, I listen to the podcast, and like I couldn't imagine, because like I was understanding the terms, but I just imagine like a lot of people saying like, I don't understand what she's talking about. And then I found later the exercises, so that was very nice.
Yeah, thank you.
Okay, well, I think we talked enough. Anything else that you want to add, or anything that you want to say to the audience before we end?
We went way over time, didn't we?
I mean, there is no time limit. Whatever we wanted to talk about, if people are still listening to us.
You better chop it up in pieces if you can. Nobody's going to sit still this long.
Well, people are, usually they're listening, they're moving around. And
I see. Oh, good. Just like me, I listen to books when I walk. Yeah.
Okay, well.
Marion, it's been a delight. I hope I didn't talk too much, but I've had fun sharing my opinion.
I really enjoy and learn a lot, so I think all the listeners are going to appreciate all your wisdom and insights to help them progress on their career and their patient care. So thank you so much.
My pleasure. Thank you.